My name is Dr. Al-Ola Abdallah. I'm one of the myeloma physician here. I'm the director of the plasma cell disorder program, and as well, I'm an associate professor at the internal medicine here at University of Kansas Medical Center. Have been working here since 2016. I'm gonna go to talk about the belantamab based on the DREAMM-7 study, and just a little bit review about the belantamab. This drug was initially approved years ago based on the DREAMM-2 study that showed efficacy in patients who are heavily treated from single arm, that showed efficacy of the belantamab in triple refractory myeloma. And we had now randomized trials that include DREAMM-7 trial that showed a combination therapy using belantamab in addition to Velcade and dexamethasone, and it was compared to standard of care of therapy, daratumumab, Velcade, and dex in patients who have relapsed myeloma, especially in early relapsed myeloma. And the results of that showed impressive, outcomes, as we can see that the response rate was in the belantamab arm higher in terms of 83% versus 71% in the daratumumab based arm. The complete remission and better results were 36% in the belantamab arm versus 18%. And duration of the response was impressive as well in the belantamab arm, that was 40 months versus 17 months in the daratumumab arm. This was reflected in the progression-free survival, that the median progression-free survival in the belantamab arm was over 37 months, around 36 months, and the progression-free survival in the daratumumab arm was about 13 months, which means it was 3 times higher than the standard of care arm, showing the improvement in the progression-free survival. And recently, we have seen our new updates from the survival benefit, that the belantamab Velcade dex show a 42% reduction of the risk of death comparing to the Dara Velcade dex arm. So the DREAMM-7 study actually kind of confirmed, efficacy of the belantamab therapy, combination therapy, comparing to the daratumumab combination therapy, not only in terms of response rate and progression-free survival, but also the overall survival as well, that we're seeing it, especially in the 36 months overall survival rate. I think this is a very important thing, is that the belantamab is a very important BCMA targeted antibody drug conjugate. And what does that actually mean? So we have to understand two major significant things. Is the BCMA, what it means, B cell maturation antigen. It's a very significant target expressed a lot in myeloma cells, over 95% of the time. And we know that this BCMA is very important as a target for other BCMA directed therapies. But the belantamab itself, it's an antibody drug conjugate, which means like it has an association with a cytotoxic potent agent, which we call it the MMAF, or monomethyl auristatin F. It's a microtubule inhibitor. So you can call it like it's a cytotoxin or a toxic agent that's associated with the belantamab antibody. So what happened is that when we infuse this drug and it goes and attached to the myeloma cells through the BCMA, this drug will internalize and put the chemotherapy agent, which is the MMAF, inside this cell, and it will causes self-destruction or cell death, or what we call apoptosis, and destruction of the myeloma cells. Now, this is one of the mechanisms of action of the belantamab. However, there's other mechanism of actions that also plays, like through the immune-mediated effects. So the belantamab itself can induce antibody-dependent cellular cytotoxicity or antibody-dependent cellular phagocytosis. So it makes your immune system also attack the myeloma cells. So this is how much this belantamab works as in terms of mechanism of action. Now, a lot of physicians or clinicians always ask the major differences between belantamab and other BCMA-directed therapies, which is the two CAR T cells that we have, cell-to-cell and Abecma, and also the other bispecific drugs like erlantinib and teclistamab. We always kind of like make sure that everybody understand that the cellular therapies have a different mechanism of of action. But the major difference is that belantamab is off-the-shelf treatment and it's always outpatient therapy. CAR T cell, some of the cases, some centers are doing it outpatient, but still it's an issue for some centers. They still have to require to do it inpatient. However, off the shelf is not something that we see it in CAR T cells because it requires leukapheresis and manufacturing, and sometimes you need bridging therapy. While the belantamab have a benefit, it's off the shelf and it can be given outpatient for these patients. Number two is also the availability of the belantamab to be given for patients who are maybe or most likely are not candidate or suitable for CAR T cell. And this is still an issue for patients like elderly patients or who are frail, that they cannot undergo CAR T cell or they cannot also even receive any of the continuous bispecific therapies. So belantamab can cover that portion of patients, populations of patients that need that. Other differences that we know between belantamab and CAR T cells or the bispecific is the toxicity. We know that belantamab doesn't cause any of the major toxicity we are aware about that commonly, the cytokine release syndrome or the ICANS, the neurological toxicity. And it doesn't, as we talked about, require hospitalization for step-up doses for these things. However, one of the distinguished features of belantamab, it's the ocular events that we see it in these patients, which we can talk about it, the keratopathy and the blurry vision that these patients complain about it from the chemotherapy MMAF that causes that. However, we always kind of like make sure everybody aware is that it's required for these patients who receive belantamab to see an ophthalmologist prior to every dose they receive. We have to be very clear about why the FDA advisory committee or ODAC, kind of like voted no for that. So the first thing is that they didn't vote against the efficacy of the treatment. They actually acknowledged the fact that the treatment has been fairly effective, and even both not DREAMM-7, DREAMM-8 also, which was another a randomized trial. So there was a clear benefit of progression-free survival 3 times higher and overall survival advantage and a durable response rate. So I don't think there was any rejection in terms of the anti-myeloma efficacy, but I think there was a question mark about the ocular toxicity, that they were actually not very satisfied about the keratopathy, the visual symptoms, the requirement to see an ophthalmologist. And I think there was a concern about the dosages and the frequency. Could that be a lower dosages? And if the company actually have clinical trials to actually have a proposed lower dosage to decrease the rate of keratopathy and eye toxicity. That was the biggest issue here. Number two, they felt like the ocular toxicity in this phase could be actually have an impact for the patients, especially there's other options of therapy for early relapsed myeloma that include the CAR T cell that are approved and the daratumumab based therapy as well, like was available with less toxicity. So these were main things that the ODAC actually was focusing on in that regard. But they have acknowledged the fact that the treatment is really effective in myeloma patients, especially after comparing it to daratumumab. One of the things I want to add is that, in terms of the efficacy, there's a few things I want to add. The toxicity is, I think, a major issue to talk about it, which ocular toxicity have to be, addressed for patients that decrease their anxiety. So the expectation about that, always to inform the patient that, although there is that blurry vision or keratopathy, that also the majority of these patients are reversible. There's no permanent vision loss. It's rare, very rare. And we always have to make sure that these patients are seen by an ophthalmologist regularly prior to the dosages. And there is like a way that there is a big connection or communication between the ophthalmologist and the oncologist that actually is giving this treatment. So we have to make sure that this is also something they are connecting in that. Other side effects, like it's really tolerable, like thrombocytopenia and infection. So I think that is always, aware about that for these patients. Last thing I want to add is that this is an option of therapy. I know it's a lot of physicians are asking about the common question, do you really need to use this treatment? I think that's commonly we have to understand myeloma, it's incurable disease. And using BCMA-directed therapy, I think the best question we have to ask is not are you going to use belantamab or CAR T or bispecific first? I think the commonest question is that how are you going to sequence the therapies? And I think we always have to advise, if a patient is a second line of therapy, I mean, CAR T still could be available, but I don't think we can give patients a bispecific in a second line of therapy. If the patient cannot receive CAR T cell, belantamab will be an option of therapy in the second or third line of therapy. So we do have an option for using this treatment. And also the question about how we can sequence that, I think it's still, advisable is to kind of like follow the guidelines in that regard.